Welcome to our first COVID-19 Journal Club from Manchester Royal Infirmary and the Royal College of Emergency Medicine. Can see people starting to join. Thanks for joining us. I'm Rick Boddy, and I hope you'll be able to see in a moment a presentation, our screen. There we are. So first time we've done this, might be a bit rough and ready. There might be a few little rough edges, but we'll see. We'll iron out the problems as we go. And we hope that we're going to do this roughly once a week. So we'll appraise some of the latest literature. Great way of finding out the latest in coronavirus research and then applying it to our practice. We've been doing Journal Club every week at the Manchester Royal Infirmary for quite a number of years, and we find it a really important element of our practice, actually, a chance to praise the latest evidence and then actually discuss how it relates to our clinical practice. So that's what we hope to do here. I'm going to just skip through and do a little housekeeping first of all. I don't know if you've joined webinars like this before, but I just want to point out there's a few ways that you can contribute. So you'll notice you can see the video of the panelists, but you can't see the video of the delegates, and you're automatically muted in a webinar. But we do want to get your contributions. So if you want to ask any questions, please use the Q&A function. So if you hover either at the top or the side or the bottom of the screen, wherever it is for your Zoom account, you can see a black sort of toolbar. And when you hover over that, you'll see Q&A. If you click on Q&A, you can ask some questions. We'll see the questions and then we can address them live. So please use that. Also, you've got a chat function in there as well in that same toolbar. If there are audiovisual issues, anything that's bothering you or anything you'd like to chat to other delegates about, then please use the chat function and you can interact on that. So that brings us on to some introductions. So quickly, I'm Rick Boddy, a professor of emergency medicine in Manchester, got an interest in diagnostics. And I'm now going to hand to Paul Clapper.
Apologies, I was on mute. Paul Clapper, Professor of Clinical Virology at the University of Manchester.
And Charlie?
Hello, I'm Charlie. I'm an EM trainee and an NIHR doctoral research fellow.
Pam?
Hi, I'm Pam Valley. I'm Professor of Medical Virology at University of Manchester.
And we have Anissa.
Hi, I'm Anissa Jafar. I'm an EM trainee and academic clinical lecturer at the University of Manchester.
And we've got Simon.
Hi, I'm Simon Cowley from St Emlyn's. I also work with Rick. And there's loads of stuff going on in the background here, so I'm not entirely sure what's going to come through that door any moment now.
So really privileged that everyone here can join us. Really expert panel, so thanks a lot for taking the time out. Here's what's going to happen. We're going to go through one paper in more detail. So Charlie's going to take us through a deep dive of a paper published by Guan et al. In the New England Journal of Medicine, looking at the clinical characteristics of coronavirus disease. And then we're going to discuss that. Following that, we're going to have some rapid fire reviews. So we want to cover as much evidence as we possibly can in the short time that we've got available. So we've got 5 papers. We're going to summarize them very succinctly for you and then discuss the implications of them. And so we plan to do that within 1 hour, which is going to be tight. So without further ado, let's move on to our first paper with Charlie going to tell us about this paper from the New England Journal by Guan et al.
Thanks, Rick. So Guan et al. Set out to do a retrospective cohort study examining confirmed cases of COVID-19 in China. Can we go to the next slide, Rick? They only looked at PCR confirmed cases, so there are no suspected cases in this cohort. They looked at this very early in the epidemic in China. They looked from the 11th of December through to the 29th of January. The data was extracted locally and transferred to a central site where 3 external clinical academics reviewed the data. They had a fairly robust method for seeking out missing data, and to a degree their data was cross-checked to look for any abnormalities. They seemed to have the appropriate ethics in place to conduct this review. They had one primary composite endpoint, which was either an ICU admission, mechanical ventilation, i.e. being tubed, or unfortunately the patient passing away. Can we go to the next slide? So they found 1,099 patients. Now that now doesn't seem like a lot, but at the time there were just over 7,700 cases in the whole of China. So that's quite a large proportion. And actually they got 29.7% of hospitals in China to submit at least one case. So they had quite a good capture within the time frame they were in. Of those cases, 72.3% of them had contact with someone from Wuhan, and 25.9% of them didn't have contact from anyone in Wuhan. As you can see here, the median age was 47. Most of them were male, and 23.7% of them had a coexisting condition. Interestingly, and something we'll come back to later, was that 85% of the patients in the study never smoked, which might be low for China. Moving on to some of the results that they showed through, the main bit of this paper, and one of the strongest points, is describing the symptomology of COVID-19, and that is one of the strengths. It was really variable. There were low respiratory tract symptoms, upper respiratory tract symptoms, and vague viral symptoms. It went from cough at 67%, fever at 43%, fatigue 38%, sputum production 33%, myalgia nearly 15%, headache 13.6%, sore throat, nausea, vomiting, diarrhea. So there's a really wide range of symptoms that they described here. They also, on admission, categorized people into severe and non-severe pneumonia. Now, this was according to an American definition from the American Thoracic Society, and they defined that 15.7% of patients had a severe pneumonia. They also went on to describe the characteristics of various blood results and imaging results for these patients. Some of the more interesting bits are around the full blood count findings. As most of you may already be aware, lymphocytopenia was a major feature here. 83% of patients on admission had lymphocytopenia. Thrombocytopenia was quite prevalent at 36%, and leukopenia at 33.7%. The CT findings were quite interesting. They found that 86% of all patients had an abnormal CT finding, and 56% had ground glass opacities. They managed to do an interesting analysis around median incubation, i.e. the time from exposure to the time from symptoms. Now, unfortunately, this wasn't possible in all of their patient cohort. They only got it in just over a quarter of them because of incomplete data. But they found a median time from exposure to first presentation of symptoms to be 4 days, which is an interesting statistic to think about. The median length of stay in hospital was 12 days. A lot of these patients got antibiotics, 58%. Just over a third got Tamiflu, and 41.3% received some sort of oxygen therapy. In terms of the primary endpoint that they described, that composite endpoint of death, ICU admission, and being tubed, they found that 6.1% of their cohort had it. However, there are some issues with that. So that's the overview of the study. Retrospective cohort study captured just over 1,000 of the 7,700 cases that were going on at the time. It was pulled together really quickly. They had some good data validation measures, and they've described the symptomology and some of the investigation findings really nicely. And I think I open it up to the panel.
Thanks a lot, Charlie. So I'll bring up the tables from the paper so we can illustrate our discussion with some details of the tables as well. Really nice summary of the paper and very interesting findings. Let's go first of all to Paul. Paul, what do you make of this paper, and anything in particular that jumps out at you as being relevant for our practice?
Not for me. I mean, it's additive to what we already know about the the illness, and the more that we get out of China, I think the more we can learn.
Sorry, Richard. One of the things that struck me about this paper was how few of the patients being admitted to hospital had fever. And is it 43% on admission? Although most of them went on to develop fever later on, it sort of shows the evolving nature of the symptoms, because certainly that's all we've been talking about. Have you got a fever? Have you got a fever? And it just goes to show that perhaps many people at the beginning of this illness don't have a fever.
The other thing to say is I recently reviewed a paper from China showing that many of the patients have co-infections with other viral respiratory pathogens, but also bacterial and fungal pathogens in association with the hospitalized cases. So, you may be dealing with quite complex infection events in these patients.
Yeah, absolutely. Now we've got a couple of raised hands here. I'm going to try and see if I can come to those people. I saw a couple of raised hands among the participants and they seem to have gone down. Here we go.
Can I add a couple of thoughts as well, Rick, if that's okay?
Okay, Simon, yeah, that'd be great.
I think it is interesting that we're in this dilemma generally with the evidence around COVID-19, is that it's emerging right in front of us, and we all feel this sort of pressure to find out what's happening and to get the data out there as quickly as possible. And that's good. But it does mean that in this study, a lot of the patients hadn't actually completed their clinical course. So when we're looking at the data in your table, in table 2, and we're looking at which factors appear to predict a serious outcome, or which factors are predictive of the course of the disease, we just simply don't know because the patients haven't yet completed it. And that's a real problem, I think, because this data has then been used as these are the features that we're looking for. And as Pam says, that it's an evolving condition. We don't quite know what's going on. And so I think the quality of the data here is very, very provisional. And we're not really going to have a good idea of the strength around these risks until we've seen a large cohort of people complete their disease process.
Yeah, I think that's very true. Really important limitation of the data that we're seeing, although it's the best that we've got for now, and hopefully we'll get some more definitive data later. So there's a plethora of findings here. I've just brought up table 2 to highlight some of those things. Charlie took us through many of them, but if you look here in table 2, hopefully you can see the red dot just highlighting the biomarkers, for example. So this struck me as particularly interesting. You can see here, they've got cutoffs for each biomarker, for example, CRP above 10, procalcitonin above 0.5. And in all patients, you can see how many patients fulfilled those criteria. But here we can also see it stratified by disease severity and by whether they developed the composite primary endpoint that Charlie described. So from that, we can then start to see whether the biomarker were having any prognostic value. So you can see, for example, if the prevalence of a high CRP was higher in patients with more severe disease than in non-severe disease, and it was actually identifying a more sick population. And we can see that that's true. 81.5% of the cases that were severe had a high CRP compared to 56.4% of the non-severe. And you can see here, this is where we get our data on LDH, for example, being useful in this context, that LDH was more commonly raised in patients with severe disease, a lot of liver function tests, the ALT, AST, bilirubin, and also, interestingly, the dimer here, which was higher in the patients with severe disease. What do you take out of that? I mean, do you think that's something that we should use in our practice? Do you think these markers are all markers that we should be measuring?
I'm going to be skeptical again, I'm afraid, sorry, Rick, on this, because the numbers are quite small, and they've said in their paper that they're not going to present these numbers with confidence intervals because it is a purely descriptive paper. But the sort of the back of the fag packet calculation of the precision of those estimates and whether or not they are true differences, when you're getting down to numbers of around about 50 patients, I think we've got to be quite cautious about it. I think there's a signal here, and we need to think about how we use those in future. But I'm still a little bit cautious. I'm still a little bit skeptical. I think they probably will turn out to be important, but quite how important, I'm not yet sure.
Yeah, okay. How about CT? Let's talk about CT for a moment. So here we can see at the top of the table the prevalence of abnormalities on the chest X-ray and abnormalities on the CT scan. And what we've been hearing from different countries is that they tend to use a lot of chest CT in the initial workup of these patients. So here we can see actually quite a lot of patients had normal chest X-rays. We see in total 59.1% of patients having abnormal chest X-rays, whereas 86.2% had abnormalities on a CT scan, suggesting that the sensitivity of the CT scan will be greater. So do you think that means that CT scan should be used routinely in this patient group? Is the chest X-ray usurped?
Well, there's some prospective data out of Italy which reinforces that point, and in fact punts at a higher sensitivity than that data might suggest. But the problem with all of this is that the gold standard diagnostics of the PCR detection of SARS-CoV-2 might not be that sensitive in and of itself. So I'm not sure we actually know with any degree of certainty how sensitive that test is. And I think I'd invite Pam or Paul if they have any particular comments on the sensitivity of the PCR swabs. Pam, have you got any thoughts on that?
So I think that one of the main issue with the sensitivity of the swabs is in the testing. I'll probably hand over to Paul in a moment because he's done a lot more work around this than I have. But as I understand it, most swabs that are initially negative and then turn out to be positive and negative again are because the swab hasn't been taken properly. You have to really get right down into the throat to get a proper sample. Paul, I'm sure you've got more you can say about that.
Yes, it's well known that the quality of the swab is really, really important. We learned that in the influenza A H1N1 pandemic, that you get such variation when you increase the number of people taking throat swabs. People who have never taken a throat swab before start swabbing patients. And their idea of a throat swab is you pop it in the mouth and waggle it about 10 centimeters in front of the tonsils and call that a throat swab. And then even though you're using super sensitive diagnostic tests, you're looking for vanishingly small amounts of virus in a poorly taken swab. So the Achilles heel of all the testing is really the quality of that swabbing. And we did try in H1N1 different ways of improving sensitivity, taking nose and throat swabs combined and trying to do throat washings, but really you cannot beat a good, well taken throat swab.
So you've also had a contribution from John Pickering, who's joined us. So I'll just make this question live. It's submitted by the Q&A, and John's signposted us to a paper published on the sensitivity of CT versus PCR. I think this might be the Italian paper, where the sensitivity of CT was 98% and PCR was 71%. Interesting comparison there. I don't know if I click done on this, I think that you will then, the delegates will be able to see the reference to that and the URL of that paper that John has shared with us. I wonder therefore, Paul, if actually part of, based on what you're saying, if part of the problem with the diagnostic, with the PCR assays, is that not just the sensitivity of the analytical sensitivity of the test, but also the training of the clinicians. We need to be careful about how we take it.
Also, of course, in hospitalized patients, in the seriously ill, the sensitivity of the PCR reduces as the infection descends to the lung. And then you may need samples from the lung to actually be able to monitor the infection, because essentially the infection's moved.
Yeah. There's maybe another time we'll cover a paper which shows a sensitivity of different sample types as well, which was quite interesting. So just to draw this one to a close, clinically, in Manchester at least, we're not routinely using chest CT for our patients. We use chest X-ray as a first line. And I think from a pragmatic point of view, I'm going to carry on doing that, because most of these patients that I'm seeing do have characteristic changes. Simon, would you see that you'll routinely change practice to using CT on first line?
I think we could use CT in those patients in whom there's a diagnostic dilemma, because we are seeing some patients, and it might not be that whether or not we think they're COVID, but we may think there be a coexisting pathology. And I think the conversations we've had, we've all worried about missing the patient with a PE or assuming that everything is COVID-19. So I think there will be the patients who've got diagnostic uncertainty. And of course, the other modality which we're using, for which there isn't fantastic data for yet, but is, there's some, again, observational data that is better than chest X-ray, is ultrasound.
Yeah, very true. Yeah. Which
let's not go there. We don't want to stop. I don't want to open the ultrasound box today. It's
another
too scary.
So we've got 3 questions. I wonder how we can get through, how many we can get through, because we want to move on about 25 past. So I'm going to take the first question here, which is, I wonder how the proportion of the Wuhan patients who are hypoxic on admission compares with what we are finding at hospital admission now in the UK. Are we in primary care putting patients off admission until they're more seriously hypoxic? And does it matter? Charlie, I don't know if you can remember from this paper if they reported the proportion of patients that were hypoxic.
I don't remember seeing off the top of my head. I'm having a quick scan now.
We've got complications here in table 3, I can see, which talks about ARDS, but I don't remember seeing anything about hypoxia specifically. Oxygen therapies here, which is given in 41%. So I'm not sure we can answer that question from this paper. And also whether we can answer whether it's true or not. I mean, that delaying hospital admission actually has any impact on the outcome of these patients, because I don't know that we know that.
Or CPAP or ventilation.
Absolutely. Yeah, we just don't know at the moment. We're assuming that what we're doing is right to address this oxygenation, but how low we can tolerate without doing anything about it, we just don't know. Now, we're going to have to probably move on. And I think we've got time for one more question just to address. I think this is a really nice question. Forgive my ignorance here, but this is not ignorance. I think it's a really pertinent question personally. But what is the gold standard to which we are comparing PCR and CT? Simon Paul is a virologist. I mean, what would you say is a gold standard for COVID infection? How can we compare PCR against itself?
Well, in PCR, we can measure the amount of viral RNA that we are detecting. And there are moves to develop international standards, so everybody measures their PCR amount of RNA in exactly the same way, but those international standards are not yet available. What we do have available is digital PCR, which allows us to quantitate the amount of virus present in the samples, and we know the range of digital PCR copies of RNA that we can detect in the sample. The gold standard really is to have a PCR which will detect RNA anywhere within that range. And I can share a picture of a digital PCR, but I suspect we haven't got enough time at the moment, of the spread of results that we see with samples from it. The caveat is it depends on the quality of the sample. So if it's a throat swab, we're going to get variable quality of samples. If it's a bronchoalveolar lavage, you have the effects of dilution of the samples as you get the samples from the lungs. So there is a range, but in terms of sensitivity, we know that most of the current PCRs, the latest generation, particularly the one that's going to be used for the mass screening of healthcare staff, has got 3 independent targets for the SARS-CoV-2 virus in it. So the sensitivity now is very, very good. And we're not getting false negatives in the PCR, other than the fact that some of the samples will have very low levels of virus present in them. simply because that's the nature of the sample. So the PCR test is quite good.
So not all PCR are created equal?
No. Up to date, the PCRs, the first ones that appeared in Europe was on January the 11th, and that's been continuously refined going forward. And it's the same with all of the laboratory tests. They've been refined steadily in improving sensitivity. And the ones that we've got now are the ones that are being used now are the best that we have available, and they are the most sensitive we've had thus far in the pandemic.
Thanks, Paul. So just to add to that very quickly, we're also designing a diagnostic accuracy study, and I find that the gold standard is very challenging. So we are working on the principle that we'll actually have to use an adjudicated diagnosis, using all of the different modalities, imaging and PCR together. But of course, how you evaluate the sensitivity of CT, for example, as a standalone is very difficult, because you're really just comparing different methods, and otherwise, the adjudicated diagnosis, you're going to have some incorporation bias, whereas the CT forms part of the gold standard. So, very good question. There's one more question on there, which we won't have time to answer live, but if any of the panelists can type an answer into that, that'd be fantastic. But we better move on in the interest of time to our rapid fire round, where we're going to talk through 5 papers in a rapid way. So I'm going to hopefully go back to the presentation here and move on. So first of all, we're going to go to Pam to summarize this really interesting study looking at ACE2 receptors in COVID-19 infection.
Yeah, thanks, Richard. So this paper, again, came out of China from Zhu et al. And it's really looking to try and provide an explanation for the multi-organ failure that we're seeing with some COVID patients, which is, unusual with the coronavirus infection. So it's known that SARS-CoV-2 and SARS before it share a similar spike protein that has a strong binding affinity to the angiotensin converting enzyme type 2, the ACE2 receptor. And so the widespread understanding is that cells expressing ACE2 can be target cells for the virus. For example, alveolar type 2 lung cells express ACE2. So here the authors are hypothesizing that the ACE2 expression pattern in various organs, tissues and cells might dictate the way that the coronavirus spreads around the body. So what they did was to look at some already existing published data that's held in various databases, sequence databases in various organizations. So they looked at single cell RNA sequencing, where they take next generation sequencing technology to look at what messenger RNA is being expressed in an individual cell, and that sort of says what that individual cell potentially, what proteins could be produced from that individual cell. And they looked at that in all the different tissue types shown on that diagram. Based on that, they've concluded that the organs in red there have got high ACE2 expression, and therefore might be much more susceptible to invasion by the virus. And the ones in grey are least susceptible. So I think there are some strengths to this paper, and nobody's looked at that before. That's a really interesting thing. I think there's also some weaknesses. So what they're measuring is ACE2 expression. They're not measuring viral infection there. It's not sort of thinking about the roles of secondary infections or sepsis or inflammatory processes and so on. So liver is in grey there, and we know that some patients, not many, but some patients do have serious liver problems as well with this infection. And not related to this paper, but there's been a couple of very recent papers, again out from China, from Chu et al., which are suggesting the exact opposite. In fact, that there's a negative association with ACE2 expression and viral infection. So, I think it's interesting. I think it's something that needs further looking at, but it's by no means a kind of a map to where you should be looking, I think, for this virus in your patients.
Thanks a lot, Pam. It was really interesting to read this paper, because I think it got everybody thinking about the importance of the ACE2 receptor pathway. And you can see the clear correlation between what we've read in the paper bag 1 and what we see in the clinical environment, and the areas where ACE2 is expressed in abundance here, because we see the pneumonia, we see possibly myocarditis, certainly cardiac complications, we see diarrhea, we see anecdotally, and I'm not seeing this published, but we see plenty of patients with dysuria, and we get upper respiratory tract infections, we get liver function abnormalities. So all of those areas that are highlighted on that slide, we see symptoms and biomarker derangements. So it passes sort of face validity. What does everybody think from a clinical perspective? Is this going to change anything for us? Does it make you amend your practice in any way, or change the way you think about this disease?
I'm not sure it changes the clinical practice necessarily at this stage, but it does link into the purported mechanism of why perhaps some people suffer from coronavirus much more severely than others, because we do know there's quite a lot of polymorphism around the ACE receptors. This has been described in critical illness in the past, that can be a factor. And because one of the things from a clinical perspective is why is it that some people are getting these incredibly mild diseases, and why are others getting the cardiovascular collapse, the severe lung infection, and are producing more gastrointestinal effects? It makes you wonder whether or not this is one of the potential mechanisms for that. And also there's been the controversy, as I'm sure you've seen, papers in the Lancet around the use of things like ARBs, angiotensin receptor blockers, and ACE2 medications. And again, whether or not that is a feature in why we might perhaps be seeing more people with diabetes and hypertension apparently having worse outcomes in several of the papers.
Yeah, I mean, I think there's definitely a role here. I just think that what's been done here is good, it's valid, but it's not the whole story. I mean, I was looking at some earlier papers. I found one from 1999 that suggests that people of South Asian origin have a completely different form of ACE2 than white males. There was a study that was done in London, I think, in looking at the various ethnic populations in London, and finding no difference, interestingly, between African males and white Caucasian males, but finding a difference in the genotype and the phenotype of the ACE2 receptor in Southeast Asian males. So there's something going on, but it's early days, I think, in terms of understanding it all. And
I think I just reinforce that early days. I think this is, for me, this related back to maybe a bit of a metacognition type standpoint, in that we have to have humility with this disease, because this paper came out and suddenly we realized, oh, that's why they get abdominal pain. Maybe that's why we're seeing dysuria. The pathophysiology is still emerging. For me personally, it reminded me that there's a lot we don't know, and to sort of rock back my own certainty when treating patients with this.
It's very true. I think Edwani's pointed out that it doesn't explain the CNS manifestations, of course, like anosmia, severe headaches. We seem to have seen what appears to be encephalitis. So it doesn't necessarily explain that to us, unfortunately. And there are a couple of questions in the Q&A box mentioning losartan. There's a trial going on in Minnesota, which will be really interesting. Important between the safety of that one, because it could go either way. And also a comment about Black people being less responsive potentially to S8 inhibitors and more prone to severe COVID-19, so possibly a connection there. I think we better move on to our next paper so that we can keep to time. So next we're going to look at this non-randomized open label trial of hydroxychloroquine and azithromycin for COVID-19 infection. So I was going to summarize this one for you. This is it's received a lot of attention, I think, and certainly, you'll see Donald Trump lauding the benefits of hydroxychloroquine. I mean, it's done and dusted to Donald, I think, in this case. trial was actually quite small. So in France, they managed to get approval to run this trial of, I think, ultimately 36 patients or so, in whom they gave hydroxychloroquine to 26 patients with COVID-19 infections. And they had 16 controls who weren't given hydroxychloroquine. Now, there was no randomization process, so how they selected those patients, we're not entirely sure. And some of the patients also received azithromycin. So 6 patients who received hydroxychloroquine also got azithromycin. There was some loss to follow-up, unfortunately, as well. So 6 patients in the hydroxychloroquine group were lost to follow-up. And the reasons were interesting. So of those patients lost to follow-up on and who didn't continue hydroxychloroquine, in 3 of them, it was because they were admitted to intensive care, and 1 of them had died. So they were fairly important outcomes. And what they studied was the viral load of the patient. So they measured the viral load for patients. And by day 6, the headline figures tell us that 70% of patients in the hydroxychloroquine group were cured virologically, compared to 12.5% in the control group. And of the 6 who got azithromycin as well, 100% of them were cured by day 6. So I think I can now, hopefully you'll be able to see here the graphs. So the headline figures of this here were these impressive graphs here, which show hydroxychloroquine group viral load decreasing. And when you add in azithromycin, this green line shows decreasing even more, which look impressive. But of course, it's not randomized. There are some really significant limitations, including the loss to follow-up, the bias that introduces. So question is, can we take anything from that trial? Simon, what do you think?
I'm not a fan. I think it's interesting, and again, it speaks to this balance that we all need to know what's going on, and we need to try and find out as quickly as possible because it's a significant disease. But there's really very little evidence here apart from proof of concept, and I think it's entirely reasonable on the back of this to look at both hydroxychloroquine and azithromycin as part of ongoing clinical trials. So I think there's enough data here for us to be interested, but it's not conclusive. And I certainly don't think there's not enough here to advocate for giving those drugs at this time outside of an RCT. That's my feeling. And if I get coronavirus, I'd be very happy to be randomized into that trial.
Yeah, I totally agree with you there, Simon. You know, we can't take anything definitive from this study. The basis for the trial was that there are in vitro effects of hydroxychloroquine on the SARS-CoV-2. So Pam and Paul, I could just briefly ask you for a quick comment on that. And what are your feelings about this, the theory behind hydroxychloroquine being a potential new therapy?
Well, it's sort of bringing it in from HIV treatment. You're giving the hydroxychloroquine to try and boost immune clearance of virus. And the AZT is like the early days of treatment of HIV. It's a relatively broad spectrum antiviral. There are anecdotal reports from around the world. I've got one here from France where they treated 985 patients with this combination, had 12 deaths in one study, 1.2%, and there's another 1,003 that were treated and they had 1 death, 0.1%. So it really reinforces there might be something here, but we really need a proper randomized clinical control trial of it and see if it really does have the effect it seems to. But it's certainly not one to reject.
Okay, thanks. So let's move on to the next paper. I think the next paper, if I am right, was Anissa?
No, that's me.
Oh, sorry, Simon.
Sorry, apologies. So yes, this is another paper published in the New England Journal of Medicine looking at lopinavir ritonavir, which is in the UK known as Kaletra. It's an older HIV drug, which again has shown some promise in vitro against the coronavirus. And this is an RCT, so it's slightly better than the previous paper, where they randomized in an open label way, so no placebo, people knew whether they were going to get the drug or not, around about 199 patients, 99 in one arm, 100 in the other, to either treatment with the lopinavir ritonavir or just normal treatment. And they looked at time to clinical improvement. And the way that their primary outcome worked is they have a 7-point scale, which is a sort of a sort of categorical scale that goes from not hospitalized, doing the normal thing, right up to ECMO, death, invasive ventilation, oxygen requirements, and stuff like that. So it's a way of sort of categorizing how sick you are. And the main outcome here was whether or not they improved by 2 points. And the headline figure here is that it didn't make a lot of difference. But I wouldn't want people to go and have a look at this paper, similar to the last one, and say, well, that shows that it doesn't work. There's a number of difficulties with this paper. It's quite small, so you'd be pretty lucky to see one drug making such a big effect in that limited amount of time on its own with this number of patients. It would be a surprise. It'd have to be a massive treatment effect. So I don't think we should knock it down for that reason. And also, there's quite a lot of signal in the secondary outcomes, which we were predefined in this, that there may be advantages in terms of the time that people spent on ICU, the severity indices of some of their illness, and things like, what was the other ones in here? ICU length of stay, and potentially things like 28-day mortality. And when I was looking at the paper, I was thinking that we're looking at a disease which the major thing for us is really it kills people, and the most important outcome here, I think, is survival. And the second, I would have had that, and I think we need the trial with survival or still on ICU as an outcome for this trial. So I think there are some signals in here that it's worth having a look at the paper. It's worth having a read. It's not definitive, but I'm very pleased to say that both this drug, this combination of drugs, and hydroxychloroquine and azithromycin are now part of the recovery trial, which we're running in the UK, which we're running here in Manchester. We've recruited in our trust over 110 patients now in a week. So we're getting large numbers of people into randomized control trials with a 28-day outcome. This is a national study. There are thousands of patients now in these trials. So these are interesting signals, but I think we'll need to wait a little bit longer until we've got a definitive patient-related outcome measure to decide whether they work or not.
Brilliant, thanks, Simon. Again, I wonder if Pam and Paul have a comment from a virology perspective about the use of these antiretrovirals in this kind of situation.
Well, Kaletra is very well established. It's a combination of two protease inhibitory drugs. It's very well established in HIV treatment. It is associated with some side effects, but of course, fortunately, in this case, the side effects are synonymous with the symptoms of COVID infection. So that won't be a problem. There is interesting data. They have tried this in China, and there's mixture of reports of it being successful and not successful. There was an interesting one that Ian Hampson, who's a professor of viral oncology here in Manchester, had come across from one of his collaborators, which was a combination trial of Kaletra plus a Russian antiviral called Arbidol, and they treated something like 1,200 patients. Again, not in a randomized controlled trial, but they treated 1,234 with this combination of Kaletra and Arbidol and had only one death. So there probably is something very useful in Kaletra, either alone or in combination with another drug. And I think, Pam, you had something about Arbidol. Is it lung protective as well? You're on mute.
Yeah. I can't remember what that piece of work was that you're talking about there, Paul. There's been so much happened in the last few days.
Yeah. I had an idea. Arbidol is a Russian antiviral that is there's some controversy about whether it has actually got antiviral effects, but there's some suggestion that it might interact with the ACE inhibitor.
Yeah. To cause a sort of surfactant in the lung to sort of protect the lung. Yeah, sorry, I forgot that.
Yeah. So it's definitely one that should be in the trials, and it's good that we're doing this in the UK. And it may be that there's other combinations we could try together with Kaletra in this disease.
That's great. So loads of promising drug therapies. We've talked about hydroxychloroquine, potentially azithromycin, the antiretrovirals, losartan been talked about as well. And then there's all of the immune therapies that might be useful for the potential cytokine storm. So loads of promising stuff potentially in the pipeline. We'll have to wait and see to see if any of them actually make a difference. Shall we move on to our next study? And I think, Anissa, this is you. This time looking at the prevalence of venous thromboembolism in patients who have the novel coronavirus infection.
Thanks, Rick. Am I off mute? Yes, I am. Fantastic. So the title of this paper probably says a little bit more about what we're hoping to get from it than what we actually do, and I think that's the first caveat I would put out there. So essentially, this is a paper that was produced from come out of China. It is looking at 81 patients that were diagnosed with what they've described as novel coronavirus pneumonia, who were in an intensive care environment. We don't have an enormous amount of detail about what that means about the clinical state that they were in. And the sort of headline findings were that around, I think, 25% of these patients had a DVT. So that's 20 out of 81 patients. And part of what comes from the paper is an attempt to suggest that if you look at a D-dimer level of 1.25 micrograms per mil, you can get an 85% sensitivity, an 88.5% specificity, and a negative predictive value of 94.7%. And these are the kind of headline details about this study. I suppose the difficulty I have when reading it is I'm not sure how much this really adds to what we do or don't know already when it comes to whether it's coronavirus patients or any critically unwell patient that's requiring ICU. And the devil's a little bit in the detail because you can get a little bit blinded by the numbers. But some of the commentary is obviously all based around small numbers of patients. But comments like older people who have more underlying diseases are more likely to develop venous thromboembolism is not really something that I think any of us would consider to be new or novel, but it's been being put forward as an association perhaps with coronavirus. And again, the commentary around abnormal blood coagulation being associated with poor prognosis, again, is this a signal that comes from coronavirus pneumonia or critically unwell patients? So that's a little bit tricky, and the detail around the patients doesn't allow you to pull that apart very well. And again, we've got to remember that this is a very, very small number of patients. So it's difficult to know what to say about this type of paper. In some respects, information is good. In other respects, it adds to a collection of information that may detract away from what we need to be finding out, which is the characteristics of the disease, and perhaps not thinking about things more generally. What was interesting was that none of these patients received thromboprophylaxis, and that just slips in there in the methodology. So what anybody takes from this, it's very, very difficult to say whether it's relevant, irrelevant. I don't want to be disrespectful to the authors. What is useful is the table that talks about the characteristics of the patients. Again, it adds to our collection of information about age ranges, about whether they had hypertension, diabetes. Certainly a relatively large proportion had coronary heart disease. They've characterised that 12% had coronary heart disease, 43% smoked. It was a large number of male patients, again, in keeping with all of the information that we have. Apologies, I've got people joining me in the background who weren't supposed to. So yeah, I haven't got an enormous amount of positive to say, negative to say. It's very neutral, but at the same time, I'm concerned about the level of noise that is created by information that may actually be detracting from what we want to find out.
Thanks, Anissa. I think this one has really put the cat amongst the pigeons, really, in making us think about this. We heard about the D-dimer levels being predictive, and now we have this evidence as well. We've got somebody with their hand raised, Paul Redman. I'll just hand the mic to Paul for a second. I presume you got a question, Paul. Oh no, maybe that was an accident. Okay, so yeah, so how does it affect our practice then? What are we going to do? We're going to do not just a CT chest, but a CT PA for all of our patients?
I'm not sure that we can make that decision based on this paper. I mean, the diagnosis of VTE in these patients was via Doppler. It would appear that all the patients received a Doppler, not for any particular reason other than just course of practice. I'm not sure if that's something that we all do in all of our ICU patients globally. I certainly don't recall it from my own ICU days that every patient receives a Doppler. I do seem to recall that thromboprophylaxis was something that we tended to engage with on a more regular basis. So again, it's difficult to know, and I say the devil's in the detail, because what will often come from papers like this is a bit of noise and a bit of chatter around D-dimers, around venous thromboembolism, the significance, and actually we're still, as we've said previously in the webinar, at the very early stages of actually understanding about the disease itself.
Yeah, well, certainly our intensivists tell me that they're seeing a lot of thrombotic complications, not just VTE, in these patients with coronavirus infection. And in dosing, I saw one patient at least with a bilateral PE on top of barn door COVID pneumonia, and does make you think something must be going on in this situation. So certainly at least raises a red flag to us to think about VTE in these patients. How we actually deal with it, who knows, and whether what prophylaxis dose we should use, whether we should get them treatment dose at low molecular weight heparin, who knows, it's early days, but certainly tells us that we ought to be thinking about it. We better be moving on to our last paper, which Simon's going to take us through, prediction models for diagnosis and prognosis of COVID-19 infection, which is a systematic review.
Yeah, so this is just going to be a quickie, really, which I think in some ways is going to encompass what we've been talking about as we've been going along. This is a paper that was published in the BMJ just last weekend, where a group of researchers led by Laura Winants have gone through and had a systematic review of all the papers out there looking at prediction models for either diagnosis or prognosis around COVID-19, because that's what we want at the moment, isn't it? We want to know what the good quality evidence is out there. We want to have a model which is going to help us diagnose the patients. We need a model which is going to help us prognosticate for them, both what their future clinical course is and whether they're going to survive the illness. That's kind of what we're seeking. And there's a lot of data that's flying around out there. We've looked at 6 papers today, but there's plenty more knocking around. And people are making decisions on these papers which are published. However, if you look at the quality of those papers, maybe quality is not the right word because it's an evolving picture, but if we look at the scientific basis for the predictive models, it's actually pretty poor. And there are some common themes that we find in these papers, some of which the sort of papers we've discussed today, is that they'll just look at ICU patients and say, well, the incidence of DVT or VTE is this, but not compare it with another group of ICU patients. So do we know whether it's better or do we know whether it's worse? And they'll take a group of people and they say, we've got this model and this model predicts exactly what would happen with the group of patients that we've seen, but we then haven't validated that in another group to know whether it was just overfitted with the group that we've seen. And Rick's work in particular and the group here in Manchester have got a huge experience in diagnostics, and we would never suggest that a tool is predictive until we validated it in different settings, in different groups. And again, going back to Anissa's paper, we routinely give thromboprophylaxis to every patient that's admitted. That's not just in COVID, every patient who's admitted unless there's a reason not to. So that's clearly a very different group to us. And this whole thing means that we are in a really frustrating but also fascinating time for evidence-based medicine, in that we're actually seeing it happen in front of us. And we're seeing the publications come through. We've got to keep our critical heads on. We've got to look at the data. We've got to go back to critical appraisal tools and processes and say, okay, that's really interesting. There may be a signal here, but are we sure? And so it's a nice little review there. If you want to do a bit of evidence-based medicine, you can definitely have a look through it. And as I said, the key things in the paper were predominantly around a bias around what the participants were, so looking at special interest groups in particular, and then predictors, things like using a predictive tool which wouldn't be available at the time when you were using it. So there's no point in having CT angiogram as a predictive tool for somebody who might be using it in community, because you just wouldn't have it. So lots and lots of interest there. I'm sure things are going to get better as the data comes, which is why we need to carry on doing what we're doing.
Thanks, Simon. Really nice appraisal, and a really good illustration of how we need to get the balance right. Because in this context, we've got to move fast, we've got to be agile, and we want to be early adopters. But we've still got to strike that balance between, trying to do things rapidly to respond to this catastrophic situation that we're in, but also trying to keep some standard of evidence-based medicine around. So, I mean, I guess there's some value in the evidence that's being presented, but these prediction models, have a limit. And that we perhaps just can't take them off the shelf and use them as they are. We can take some value from the data that's being presented.
I think I go back under these circumstances to a quote which we picked up several years ago, presented at SMAC, from Maya Angelou, which is that we should do, I'm going to get this wrong now, we should do the best that we can until we know better. And when we know better, we should do better. And I think we're going to see an awful lot of that over the next few months. That right now, this is the best we've got. Let's do this. New evidence, it changes, and we're going to have I love the word agile at the moment. I think it's going to be the key determinant of whether we do this well, is our ability to be intellectually and organizationally agile. Yeah,
I totally agree. And it seems like we're doing a lot of about turns at the moment, turning 180 degrees and going the opposite direction, but ultimately we will get there.
I agree. And I think as I say, I think it's an incredibly interesting, although sometimes terrifying, and incredibly sad, an incredibly interesting time to be in clinical medicine.
Yeah. So on that note, that's a really nice way to wrap up, really, at the end of this journal club. Just is to say thanks to all of our panelists. We've got a slide here from Charlie. Charlie, you wanted to ask a question here. Have you seen an interesting paper? I think this is your call for people to contribute to your RChem initiative.
Yeah, so every week we're publishing the top 5 papers that's coming from the RChem CPD COVID team, and we're pushing it out, and it's open for anyone to send an interesting paper with a little paragraph written about it, and we'll publish it either in the top 5, or there'll be a director's cut version that will come out every few weeks. We'll put a link out on Twitter after this, so if you see anything interesting, please let us know.
How do they get in touch, Charlie?
We'll stick a link out on Twitter after this.
Great, okay. So moving on, here are some references. We've also sent the links out. This webinar has been recorded, so we'll make sure that that's made available, hopefully via RChem Learning. Simon?
Yeah, I haven't had that conversation just yet, but I'm hoping so.
Okay, sorry, I'm jumping
yeah, so the plan is, I mean, this is a collaborative thing, isn't it, between guys at the University of Manchester, the hospital here, the group of us who work on St Emlyn's, the college, and it's just a fairly loose group of people. We're going to try and get the message out as widely as we can, so that we reach the greatest number of people. But what I'd really love people to do is to take these papers into their department, people who've not been here today, and have a conversation with them as well. So, spread the word. However you can do it, just spread the word.
Brilliant. And just to mention, we are going to do this again next week. So this time next week, we're going to have another COVID Journal Club with another rapid fire a coverage of the literature and a deep dive into one paper. So I hope you've enjoyed it. Give us any feedback you can, so we can make it better for next time, and keep safe, everybody. And particular thanks to all of our panel for joining us today and giving us expert insights. Take care.